evening, everyone. It is my pleasure to invite Dr. Sujit Gupta, sir. Dr. Gupta is Director, ACTREC Mumbai and Professor of Medical Oncology, past convener, Gynecologic and Breast Oncology Working Groups at Tata Memorial Center, Mumbai. And I invite Dr. Sujit Gupta, sir, to take the proceedings.
Thank you very much, Mr. Rajesh Sharma. Good evening and good morning or good night, ladies and gentlemen, depending on the time zone that you may be located in. It is my pleasure and privilege to welcome all of you to the second half of the International Masterclass that began on last Saturday. We had some excellent discussions, and I also had the privilege of moderating one of the panel discussions on that day, which led to some very nice and interesting ideas on how to make treatments accessible in low and middle income countries. We have a great agenda ahead of us today. We begin with a topic and a theme that is seldom discussed explicitly in many of the conferences, but which possibly lies at the core of how we practice medicine, which is patient-reported outcomes. And I invite the speaker, Dr. Paul Cornish from UK, to begin with his presentation. But before that, Rajesh, perhaps you can show, yes, Dr. Cornish. Can you please put up the slide introducing Dr. Cornish, Dr. Paul Cornish? Yeah. So he's an oncologist from UK, trained at the Oxford and in oncology at the Royal Marsden Hospital. He has a special interest in supportive care and has actually delivered many talks, including to us in the recent past. So Dr. Cornish, all of us are looking forward to listen to you.
Yeah. Before we go ahead for Dr. Paul Cornish's talk, we would like to take two poll questions. Kalpesh, can you put up the slides? So we have 6 questions, and before each talk we are going to have that. So we will have 20 seconds to go. On a scale of 1 to 5, do you feel that routinely capturing patient-reported outcomes in clinical practice will have a valuable impact? On a scale of 1 to 5, you can vote now. We have 20 seconds. Here we have the poll results. Kalpesh, you can show that.
Rajesh, if I may ask you, how do we actually vote?
Sir, it is there on the portal. For the, it is not on the faculty here. It is on the, for the delegates.
Okay, I thought we were also required to vote, and we would have loved to vote, but we don't have the opportunity. That's fine.
Yeah. Yeah.
50-50.
Yeah. Then, so Kalpesh has shown the results. Now we go to the second question.
Kalpesh, so, but what are the results? Hello. I can't understand the result. It just shows 2 tall bars, option 1 and option 2. But you know, the question had 4 options. So fairly important, very important, not important. So which one of those is this?
50% have given. Kalpesh, people have voted for only 2 options. We had 5 options.
But which are those options?
So I think Kalpesh is giving me a signal that we have to go for the lecture of Dr. Paul first. So I invite Dr. Paul Cornish to have his lecture, and after that we will have the polling again.
Okay, excellent.
Yeah.
Good day to you all, and thank you for joining this session on implementing patient-reported outcomes in clinical practice. I'm Dr. Paul Corns, an oncologist from the United Kingdom. I work with the Comparative Outcomes Group, and I'm a core lecturer for the European School of Oncology. In the ESO, My interest is in innovation, and PROs, patient-reported outcomes, are no doubt an innovation for many of us. Here are my disclosures. Now, this is just a short introduction to the topic, and we'll then have a discussion about the pros and cons of this process. So I'm going to cover just 3 topics for you. What is a patient-reported outcome? What is not a patient-reported outcome? And what are the methods? You know, it's often easiest to start by telling you what is not a patient-reported outcome. And that's an outcome reported by someone else, such as when we record the response rate of a tumour on a scan, or a patient in a trial records the toxicity that a patient suffers using the common toxicity criteria of the NIH. Let me take an example of the alternative trial, and this is the update of the data published this year. And this studied in metastatic HER2-positive patients with a hormone receptor expression whether it was better to have single HER blockade with trastuzumab or dual HER2 blockade with trastuzumab and lapatinib. The exact details aren't crucial, but let's look at a typical report that we might get from a trial today. So look, if you're like me, you will read the abstract and say what are the key outcome measures within it. And the answer is it's going to tell us about overall survival, progression-free survival, and toxicity. And the conclusions look interesting. It tells us that there's a gain in progression-free survival from the dual HER2 therapy. Well, that's interesting, so I'll now read more into the paper. So, what is it in the abstract that interests me? Well, first of all, we know that this isn't about living longer. So the question is, what about living better? As a patient would tell me, well, doctor, should I have the extra medicine that stops my cancer progressing for nearly half a year? And that's generally a good thing. Now, for those of you who kindly came to my session that opened the meeting on value-based medicine, you'll know I'm now going to ask a key question for value-based medicine. Do you live longer by having treatment A or treatment B? Do you live better by having treatment A or B? And in this situation, it's a balance. Does stopping cancer progression for nearly 6 months outweigh the burden of additional toxicity from extra medicine? Now, it's true, there is an increase in toxicity, but the abstract tells us it's mainly grade 1 and 2. It's mild or moderate. Now, to unravel that, we will need patient-reported outcomes. Now, here's the typical problem. When you read the paper, you won't find that answer, because the answer is hidden in Appendix 1 to the paper, for which you'll have to go online to read it. And you'll find the most crucial piece of information: there are no differences between the treatment arms for health-related quality of life. In value-based medicine terms, you have no added life years, you have no quality of life gain, and no QALY advantage. This is a treatment of no great clinical value to patients overall. And here's why PROs matter, because this is getting more and more common. As the number of trials using overall survival as primary endpoints decrease, we see more and more studies reporting surrogate endpoints such as progression-free survival and disease-free survival. And they only become meaningful to patients when they are coupled with patient-reported outcomes, typically showing global quality of life. After all, what matters to the patient is time without symptoms or toxicity. They don't mind whether they're feeling sick because of the cancer or from the drugs. They're feeling sick, and unravelling those differences will be crucial to selecting the best value medicines for our patients in the future. So it's clear that patient-reported outcomes are important, at least for trials. Now, these are outcomes that are directly reported by the patient who experienced it. Now, the first thing to do is to untangle pros, proms, and prems. A PRO is a patient-reported outcome. A PROM is a patient-reported outcome measure. That's a tool that we use to record the PRO, and one example would be the European 5-domain question tool. And the last, the PREM, is the patient-reported experience measure. That tells us, for example, what's it like to be a patient in our clinics, to be a patient with, say, metastatic bone disease. Now, one typical patient-reported outcome would be to discover the quality of life of your patients. Now, that can be a difficult thing to measure. Once you read the papers, for example, from the trials, you'll often find that they will use a disease-specific scale. There might be a different tool used in a Parkinson's paper, a different one in a diabetes one, from the cancer trials or the depression trials. It can be difficult. Many symptoms cross diseases. So what's often needed is a generic quality of life scale, one that you can use in every clinic for every cancer, for every disease, that won't distinguish between depression caused through cancer or depression caused through some other illness. So the European 5-question multi-domain scale is a good example. It's been validated in many very different diseases and in multiple languages and cultures. You can directly convert the values that you get into utility for health technology assessments. And perhaps as an attractive step for us bringing these into clinics, it's free to use. And there are both downloadable paper and electronic versions in multiple languages. So let's show you quickly how it's done. There are 5 questions covering 5 different domains of quality of life, and a visual analog scale where the patient indicates how they feel today from the worst ever to the best ever. Let's now do this in practice. For example, I did this in an eye clinic, and it took us about 3 minutes per patient to get this data on every patient attending. So here's an example. Imagine you're a patient who has scored that you have no problems with mobility or self-care, that your activities, for example, dressing and feeding were all right, but you're a breast cancer patient whose disease has relapsed in the bone, and you're in a lot of discomfort, and this has left you very depressed, with a quality of life score of around 65% on the visual analog scale. Now, with 5 questions and 3 answers, there are 243 potential results. This patient has scored 11133 and 65%. And of course, we can look that up on quality utility tables that we've designed for health technology assessment. And you'll see that for a patient living in that health state, 1-1, and that's useful to us. It tells us that this patient has a disease something between severe angina and rheumatoid arthritis, something that we would definitely want to treat, and we would want to see that this improves as a result of our treatment. We could score both the severity of the patient's symptoms and the benefits that we deliver. Well, now what are the PRO methods? And these are the tools, the questionnaires that we use in the trials or in other clinical settings to help us understand the patient's experience, typically to understand the efficacy or effectiveness of the treatment that we give, triggered by the symptoms identified. The methods for gathering PROs are PROMs, patient-reported outcome measures, and they can be paper-based or electronic. The role of PROMs in trials is clear. We've just discussed that, for example, in the alternative trial. But in routine clinics, the role of these tools is to trigger us to start or change treatment to better suit the patient or better manage their symptoms. And that often means triggering additional appointments or tests or changing plans that we've already made. Here's a classic example, a study of more than 700 patients starting chemotherapy for metastatic solid tumours. And in this study, the patients are randomised between the usual standard of care and having a PROM measure that just looks at 12 common symptoms of the toxicity of cancer treatment. If there's a change, it triggers an alert to the patient's nurse, and helps generate the report for the weekly clinic review with the oncologist. And this study was a huge success. It indicates that routine PROMs added almost 6 months overall survival benefit to patients with advanced disease going through chemotherapy, with a hazard ratio of death of 0.83, making this the equivalent of a significant advance in a new cancer medicine class. There are lots of meta-analyses out now, so I won't go through each one, but basically, used in trials, PROMs have enabled better survival, improved quality of life, higher patient satisfaction, better communication between patient and physicians, improved symptom control, less time in hospital, less emergency attendance, and people are able to continue on their standard chemotherapy course for longer. And it benefits us too. With better communication between patients and the healthcare professionals, we're much more aware of how our patients are, and it helps us in shared medical decision making and in discussing topics that perhaps would never have come to light any other way. Crucially, studies show that it doesn't slow clinic workflow or increase the consultation times. There's a second role which is emerging, which is in measuring performance as patients go through treatment. We can use that to compare, for example, two different treatment policies in comparative effectiveness research. It could help drive a quality improvement initiative or help us design the health service for the future. Here's one example by the English National Health Service, looking at surgical treatments designed primarily to impact on quality of life. Using a before and after tool, about 9 out of 10 patients will comply with this. And we can see the QALYs gained by patients, many more gain than lose. We can rank hospitals across the country by the value that they give to patients, and the best ones can be used to teach the lower performing hospitals how to improve. But there is always a barrier, and the simplest patient-reported outcome would ask a patient about quality of life. In a survey of 357 oncologists, you'll see that the majority of us, 82%, thought that we should collect that routinely in patient care. But almost the same number admitted that they didn't really understand the measurements of quality of life and how to use it. In a survey of 260 senior oncologists, 8 out of 10 thought that we should routinely collect health-related quality of life scores from our patients. But in practice, only half of them said they did it, saying that they had problems with limited time or resources. Between you and me, that 50% claim, I think, is high.
Thank you very much, Dr. Paul Cornes. Now we are ready. Yeah. Yeah, we are ready with the poll. And on your screen, you will be getting a pop-up. In case pop-up is already there on the screen. You need to select option 1 to 5. You can click and submit button send. On a scale of 1 to 5, do you feel that routinely capturing patient-reported outcomes in practice will have a valuable impact? You can vote now. You can select not at all important, slightly important, important, fairly important, very important. So you can select now and submit button send.
So remember, I showed you the randomized trial. 12 questions, toxicity of chemotherapy. Let's hope you've remembered from 10 minutes ago. You want lots of 4s and 5s.
Yeah. Kalpesh, you can show the results once you are ready.
It is there on screen.
Yeah. So we have results on the screen. Most of the people have voted for option 4. That is fairly important. lot of people have voted, very important. And so majority agrees that it is important. And can we go to the next question, please? The second question is, do you think that patient-reported outcomes and value-based care go hand in hand? In case you agree, select A. In case you disagree, select B. Here we go. It is on the screen. Please vote, agree or disagree, and submit the button send.
Just remember the alternative trial. You wouldn't have known whether it was a good or a bad treatment without the patient-reported outcomes.
Yeah. As soon as you are ready, you can show the results. So
Excellent.
most of the people agree on the question, do you think that patient-reported outcomes and value-based care go hand in hand? With that, I thank all the audience who have voted, and we will have the next set of questions before the next talk. Now, it is my pleasure to invite moderator Dr. Muhammad Ibrahim Wahed from Malaysia, and in the panel members we have Dr. Govind Babu from India. He is President ISNPO and Organizing Chairman of the program. He is Consultant Medical Oncologist at St. John's Medical College Hospital, SCG Bangalore Hospitals Bangalore. He is former professor and head Division of Medical Oncology, Kidwai Memorial Institute of Oncology, Bangalore. He is currently president of SARC Federation of Oncology and was co-chair ESMO India Summit 2020. In the panel, we have Dr. Chayut Charantam from Thailand. Dr. Chayut is associate professor from beautiful city of Chiang Mai University, Oncology Unit, Department of Medicine, Maharaj Nakhon Chiang Mai Hospital, Chiang Mai University, Thailand. Then we have Dr. Christina Galvez from Philippines. Dr. Christina is oncology consultant at St. Luke's Medical Center, Philippines. She is past president, Philippines Breast Cancer Society, board examiner, Philippine Specialty Board for Medical Oncology. And of course, we have Dr. Paul Kohns. We have just heard him now and last week. A prolific speaker, and Dr. Paul Kohns from oncologist from Bristol, UK. So I hand over to Dr. Ibrahim Wahed. Dr. Wahed, are you there?
No, Dr. Wahed is not joined yet. So I think we can go with the Dr. Paul for the discussion.
So I would request Dr. Paul Kohns to take forward the discussions.
Well, thank you. And I'm sure Prof. Mo will join us in a bit.
Yeah, I think I just had a talk with his secretary some time back. He's supposed to join anytime.
Don't worry.
I think he has dropped. So we'll carry forward the discussion. Yeah.
The scores that we've seen today fit all the surveys that we've heard before. Oncologists think that collecting patient-reported outcomes routinely will be a good thing, but they hesitate. And I think the fears probably are the resources that you need, the staff training, the equipment. Are you going to use an electronic system? And it would be interesting to hear from the panelists. You know, the kind of trials I've shown you have been out for a little while now. And every department, I think, says we should do it, but I think they're worrying, how do we do it? So perhaps it's a chance for the three of you to share your experience for a minute or two. What's the discussion been in your hospital? Have you managed to achieve it? Have you managed to achieve it just in trials? Because I think all of us that do trials are used to getting the patient-reported outcome scores, but then we hesitate. In the trials unit, you have very well-trained trials nurses, lots of junior doctors want to come and assist you. But when it's you on your own in a clinic, and there are 10 patients in the waiting room getting angry because it's running late, you keep thinking, perhaps now this isn't the week to start it. So perhaps who wants to start? Who's going to start? Is that Christina? Christina, ladies first. Tell us, what's the experience in the Philippines?
So good afternoon, everyone, and thank you for the invite. Thank you, Professor Corns, for that really eye-opening discussion on patient-related outcomes. So unfortunately, yes, in the Philippines, we do a lot of patient-related outcome measures in clinical trials, but yes, there's a lack of implementation of these patient-related outcomes in our clinical practice. What we do regularly are in terms of doing nutritional assessment and doing patient experience regularly, feedbacks from our patient. But yes, we have not been doing measurements in terms of their quality of life. And I think the real problem in the country is in terms of implementation is the fact that we really do have a lack of manpower. And although even if my country is the #1 country in terms of texting, or the use of technology, but in terms of really net consistency, there is a problem with it. And so we are having a hard time on how we should be implementing it, but I agree we should be, but maybe as per institution basis, this is something that is doable. We are, in my institution in St. Luke's, we are already doing a lot of planning for 2022. And this includes also integrating all of this patient workflow in our electronic health record. And I think part of this should be also incorporating patient-related outcomes. But I think in St. Luke's, we have the technology, the IT infrastructure for this to become feasible. But it's more of like being able to pinpoint who are the cancer physician related to cancer care who will be joining me or will be interested or having that passion or that motivation to implement such program.
To me, the motivation is to think that 750 people with metastatic cancer live 6 months longer through routine use of PROs. So I'm going to talk to Prof. Govind from Bangalore, of course, the heart of India's high-tech electronics industry. And I think people have seen that already you can buy off-the-shelf patient-reported outcome electronic systems. They're sold by big European American corporations. Do you think a lot of people are waiting for an inexpensive system to arise from somewhere like India to make this implementable in practice? Because you've heard the Philippines, they're quite happy to pick their phone all the time. And Bangalore is the most high-tech place in the world now, isn't it? What's the experience there?
Yeah, thanks for that question. Actually, as we saw in the survey, everybody feels that we're doing it only for clinical trials. So, we did a study with Dr. Richard Grell, actually. He used an electronic device to collect all the patient-related outcomes, reported outcomes. And he actually was trying to show that you could do away with even imaging to look at responses. Patient-related outcomes could be just as good as imaging for assessment. So, but we have done all in the clinical trials, of course, like you said, it's been routine. I was a part of the Mona Lisa 7 study, and the patient-related outcome paper was recently presented at ESMO 2021. So, what I do is I take the symptoms of the patient, what symptoms they have when I start the treatment. And after first cycle, when they come in for this, probably the second cycle of treatment, ask them if your symptom at the beginning was, say, 100. And after your first course, how much you think it has come down? So that is a very rough way I enter in the record. So I tell my junior staff also, this is the simplest thing that we can do to record each one of them and then sum it up and actually see whether that really helps. So this is what we are doing right now. Like you said, yes, cheap electronic app, maybe that'll be useful. But I think even this is a simple way of actually looking at how patients are doing. So if the patient with lung cancer has cough, pain, dyspnea, so if these are the major ones, I tell, okay, when we started, you had 100%. How much has it come down by after one course? So that's how I'm recording now.
Very good. Well, now look, there's Prof. Chaliat there in Thailand, and you're between these great big countries. Britain and America have done the studies; they've shown very positive outcomes. It works in English, it works in the Anglo-Saxon community, and there's a good question here. Well, it works for the British and Americans, but what about the worldwide community? What do you think the experience of Thai patients will be? I mean, are they forthcoming with symptoms? They tend to be reserved and hold them back. Are they someone who'll tell a doctor that their treatment isn't working very well? Or are they very respectful? My patients tend to be a fairly direct lot, but my experience in Asia is it's not always the same. So what do you think? You've heard these different views.
Actually, it's very similar to the experience that we heard from the other panelists, that for the research setting, we do quite a lot. But then implement that to the clinical practice, we do very little. Seems like what we have done is not patient-reported outcome or PRO as your definition, not patient exactly reported or do that themselves, more like our checklist. Seems like all the European 5 question, it's in our routine checklist, but not patient-reported themselves, but more like a nursing checklist. We also more focus on the symptoms rather than some other function. So pain or that fatigue is listed there, but again, not patient-reported outcome per se, more like a checklist. So then physical symptoms have a lot of attention in the medical record. But then if you go to other function, more of the depression, anxiety, less and less have been focused on that. So no, we are not routinely do that on the clinical practice as the patient-reported outcome per se. But we do a lot of checklists, but on the medical personnel been doing that.
Now, to me, I think we're hearing the stories I've heard so many times before, that the studies that I've shown you that have been so positive come from well-resourced hospitals in Britain and America. And I think what we're looking for is hospitals in different cultures in a way to replicate the technology. Think of the studies done in Leeds and the one I showed you for the American one, where you ask 12 questions about the typical side effects of chemotherapy. And the study in Leeds, they used an electronic console in the waiting room. Patients are always waiting in chemotherapy on treatment clinics. You say, well, just while you're waiting, fill it in. And that study was very good because they recorded the consultation between the patient on chemotherapy and the doctor. And they showed that when the patient had filled in the code, 5 times as many of the patient's problems were dealt with in that clinic than without that trigger. And they showed that the timing was identical. So in a clinic, you got 5 times more done. We've all had that experience. We're talking to a patient and there's something they haven't told us, and we keep trying to find it. It goes round and round, and the time is ticking on. The nurse is looking anxious. The clinic is running late, and you wonder what they didn't tell you. And it's a way of making it come out. So I guess before we finish this session, it's an appeal really to think some of the large hospitals, there's the Actrec, Tata in Bombay would be perfect. AIMS, I spent a time as a fellow in AIMS for 6 months. And of course, now the big emerging university hospitals in the Middle East, North Africa region would be great places to rerun those studies and see, is it robust? Is it just something that's good for the kind of consumer-linked society in Europe and America? Or is it truly applicable? Because to me, a 6-month survival advantage for metastatic cancer through a medicine, we'd all be here discussing today, how do we advocate to get that in our hospital? Is it a cheap generic medicine? Is it a biosimilar? How will we get it? We'd all be wanting to implement it. And we're told, the similar benefit to a whole new class of medicines. And here we all are, senior doctors hesitating. So perhaps just before we finish this session, all of you, perhaps just a finishing thought, how are we going to persuade ourselves and our colleagues to trigger one more trial? Christina, the Philippines would be a great place to do that trial. Do you think you could bring 10 hospitals together and do it with you?
That is possible, but I think more in the national capital region, because there would be some IT issues in other hospitals. The IT infrastructure for our patients. So remember, a lot of our patients are not that, they don't have access to the internet when they are not in their homes. So their Wi-Fi, their phone Wi-Fi's are not that good. So there may be issues with it. Of course, there are language, the ethnicity, the cultural barriers that goes with it. So, but I think in order to implement this, we should just be able to find a group of people, as I've said earlier, who have the same motivation and the passion, the commitment. I think that's the term, the commitment to really follow it through and really bring it to the stakeholders, and present the importance or the relevance of implementing patient-related outcomes, because there are now a lot of systematic reviews that we can show and prove that it does work, it does impact cancer care. And so why not do it in a cancer center, especially now that all of us are saying that we are doing patient-centric cancer care. And if
Yes.
we're going to say that, we have to walk the talk. We can't just say that we are doing patient-centric care and we're not implementing it in our own institution. That would be like, like you're not doing it appropriately. I think that's one way wherein we can really totally say that we are definitely doing patient-centric care. But yes, we have to identify. And
so look, there's Dr. Govind. Can we link your two hospitals together? Do you think we could run a trial in India with the resources that India has and validate it outside Britain and America? I think that's going to be possible.
Yes,
Yeah.
we work with any countries from the
Yeah,
APEC.
that's a wonderful thought, can be done. But yeah. But the problems that I've had even in clinical trials is that many of our patients are not educated. So they find it difficult to read the questionnaire. So these people, in fact, are not a part of the PRO of the clinical trial. So that's a big issue. So there I find some sort of a visual analog scale being more useful. So I can explain to them, tell them this is this, and then they enter. So I think the barriers that we need to come around and see how best we can use it for our specific population.
Yeah,
Well, I can see Prof.
I
Ibrahim's
see
here.
that is a
We'll
big
have to
hindrance.
make this a Malaysian Oncology Society.
I don't know what happened. I joined as a
Don't worry.
Wouldn't-
Fortunately, everyone's voted as we expected. Everyone thinks that collecting routine patient-reported outcomes would be a good thing, but they're all hesitant to do it outside trials where they have trial nurses and equipment and resources. And the positive trials that we've seen have not always been in educated people. Remember in the American study, about a third of people were not computer literate. Most people with cancer are elderly. And so I think that your point about using other than word-based triggers is very important. But what I hope then is that between us, and we now have very good research setups, at least in Asia. Some of us have been attending the recent meetings that run between the oncology societies, between Malaysia and the Philippines and Taiwan and Thailand and so on in the region in India. And hopefully that will be perhaps one of the trials we can set up for the future. And there's no reason why you can't use simple paper-based tools. The EQ5D question, as I said, I've worked on, takes between 3 and 5 minutes once patients get used to it. I think there's plenty of opportunities there. And hopefully we'll then leave this session with all the people who've been with us fired up to ask the questions when the next speakers come. So what about the patient outcomes? Do they live longer? Do they live better? How do you know? And perhaps make it as a theme for this evening, this afternoon, this morning's talk from wherever you're watching. Is there anything more we should say before we sign off for the next session? Rajesh, what do you want?
Yeah, I wanted to welcome Dr. Ibrahim Wahid from Malaysia. I have already introduced sir.
Sorry.
And
Don't worry.
I wanted
You can have a
to.
final word.
Yes.
Yeah.
I agree with a lot of things that you were saying. But, Paul, you brought up something very, very important in one of your talks. You talked about everybody thought it was important, but a lot of oncologists in the UK felt that they didn't know how to use the tool.
Absolutely. Absolutely.
And that is not only a unique problem in the UK. I think it's right across everyone. It's
So here we go.
So first of all, is we need to know how to use these tools properly so that we can, implement what we want to see in patients' outcome, the questions. Otherwise, we will not answer the questions that we want to, we have asked, And then what about, what about PROM and PREM? How do you differentiate between PROM and PREM? And,
so look, we've had a short session today, but look, Prof. Ibrahim, you and I will do, many people may know that most of the year I look English, and then several times each year I become Malaysian at the National Cancer Centre there. So I think what we should do is to say, look, in the Malaysian Oncology Society meeting, we'll have to put down a session about this to take more time, run some workshops. We have run actually a program using the 5-question tool in Penang in the dialysis unit to help build the utility scores for Malaysia to anchor value-based medicine. And if all of us could say, right, we may not be the experts on this, but let's get people together for our next annual meeting of our national cancer societies and have a session on patient-reported outcomes, look at ideas, invite local industry, all the clever tech people from Bangalore and elsewhere to come along and bring their ideas to us. And then, if nothing else, perhaps trigger a trial outside the UK-American culture and see if we can do the same. Because after all, our patients with metastatic cancer on chemotherapy do deserve that. If we can really deliver a 6-month survival advantage by better managing toxicity and symptoms during treatment, we want it for all of us. So perhaps if we'll stop there, and Prof. Ibrahim, you and I will definitely do it. I'll send you an email. We'll be ready for the next meeting.
Yeah.
And we'll get a session and get some people together.
Research is always a good thing, but don't forget the clinical practice or clinical routine practice, that how to implement a good result from the research to the routine clinical practice, because we don't want to go over this topic again. Just everything looks so beautiful in the research setting, but never panned out in the routine clinical practice. So more people have to value.
Well, no, thank you. That's a very good point, because we know last week there were about 500 people from 33 countries joining this meeting. And my guess is that there's someone out there who knows a lot and was wanting to say, I've got a program that's worked. So can I tell you what would be really helpful if you've introduced this, whether it's worked well or not, please share your experience.
Because we don't want it to work so beautifully in the, all the fully equipped technology in the clinical trial, and then it doesn't pan out in the clinical practice again. So hopefully when we meet again sometime later, we have something more to talk about, but just not, again, it's a research question again.
Fantastic. Thank you very much.
Thank you.
Thank you.
Thank you.
I thank Dr. Paul Cornish to take up it immediately, and I thank Dr. Ishina Galvez, Dr. Chayut, and Dr. Ibrahim Wahed.
Thank you very much. Thank you.
Yeah.
For having me. Have a good meeting.
Thank you.
Thank you, Dr. Chayut.
Thank you.
Now team is ready with the second poll. I request Kalpesh to share the second poll, and to the audience on your screen, poll will pop up. In case because of your internet settings, poll is not popping up, you have pop-up off. So you can click on the poll button, it will come there, and then you can vote. So here is your question. What is your preferred first-line treatment choice for hormone receptor positive ABC in postmenopausal patient with non-visceral metastasis received NSAI in adjuvant setting? And your options are aromatase inhibitors, B, fulvestrant, C, AI plus CDK4/6 inhibitors, D, fulvestrant. You can vote now. We have 20 seconds. You can select A, B, C, D, and then technical team will display answers. So here we have the results. Majority have voted for option 1, followed by option 3, then option 4 and 2. So we have divided house on this. the fourth question now. I hope everybody has got a pop-up on their screen. In case you have not got pop-up on your screen, then you can click on the poll button. You can choose the option and push send button. The next question I am reading out: what percentage of your hormone receptor positive patients receive hormonal therapy as monotherapy in the first line treatment with few visceral meds? Options are A, less than 50%, B, 50 to 70%, C, 70 to 90%, D, more than 90%. Here we go. So here we have the result. More than 46% of the participants have chosen option 1. Option 2 has been chosen by 23%. Option 3 has been chosen by 7%. And option 4 has been chosen by 23%. So again, divided house. I thank everybody who has participated. Now we go to the next question. The next speaker is Dr. Christian Jekish. So I'm getting signal that Dr. Christian Jekish has not been able to join so far. So can I request in the meantime, while Dr. Christian Jekish is joining, can I request Dr. Shahina Dawood to take up? She's already there and our panel members are also there. So
you're saying that we should start this discussion first and then the lecture after?
Our plan was lecture first and then panel discussion. I would introduce Dr. Shahina Dawood. We have had privilege of having her as a speaker and faculty a number of times in India in many of the meetings organized by us. She is head of medical oncology and head of breast cancer program at Dubai Hospital in UAE. She has over 100 papers to her credit. Dr. Shahina Dawood is president of UAE Cancer Congress and co-president of Asia Pacific Breast Cancer Summit, ABCS, and Asia Pacific Gastrointestinal Cancer Summit, APGCS. So it's over to you, Dr. Shahina.
Thank you so much. And a very hot topic for discussion, actually. So I see we have an amazing panelist. I know Dr. Mohsen is there. Please put your video on. I see the Hisham Ghazali is already online. Neeti, I think you're there. I saw you come up. Maybe you can put your video on as well. So I'm just going to share my slides. It's actually just a couple of slides, because I always feel you have to have a point of discussion. So let me just hang on just a minute. Oh, what the hell am I doing? Can you see my slides?
Yes. Yes, we can see.
Right.
You can make it full screen. Yes.
Yes,
great.
Thank you. All right. So, essentially this year, or perhaps I think the last decade, has been really fascinating for patients with advanced breast cancer, hormone receptor positive. And we've seen the integration of so many different agents, including CDK4/6 inhibitors, PIK3CA inhibitors, as well as PARP inhibitors. And in the last couple of months, we've seen 2 guidelines that have actually come out. We've had the ESMO guidelines literally published a couple of days ago. And then, of course, you had in July the ASCO guidelines for hormone receptor positive, which hadn't actually been updated since 2016. So that was a huge feat. So my first question is going back to the ESMO guidelines. Now, when you look at that ESMO guidelines, in that first line, treatment if you have imminent organ failure? And remember, this is a question that we ask ourselves a lot. And for the first time, I'm seeing it actually there in the ESMO guidelines. If you have imminent organ failure, which I think they mean is visceral crisis, you give chemotherapy. Then they suggest maintenance therapy, but they don't actually say what type of maintenance therapy. So Niti, let me start off with you first. First question. If you have given chemotherapy in the realm of visceral crisis, and I have a different question regarding that, so I'll come back to you, Hisham, after I've talked to Niti. What are you going to give in the maintenance setting for a patient with hormone receptor positive, HER2 negative disease after you've attained control with chemotherapy?
Hi, Dr. Shaheen. I would like to give hormones with CDK4/6 inhibitors. That hormone could be AI or it could be fulvestrant in the first line setting for a hormone naive patient who had initially visceral crisis and treated with chemotherapy.
Okay. Dr. Mohsen, I see you're online. You put your video on and then you switched it off. Maybe we could get your video to come back on. Would you do the same? Would you give CDK4/6 plus endocrine therapy, or would you give endocrine therapy alone as maintenance therapy?
If I've started off with chemo and the patient hasn't had a CDK4/6, no. Right now, the data from the Mona Lisa probably would compel me to give the CDK4/6 inhibitor at that time.
Okay. Now, Dr. Hisham, let me ask you the more difficult question. In a patient with visceral crisis, and I completely do not agree with the definition of visceral crisis. Now, I think in the era of CDK4/6 inhibitors, we have to revamp that definition. Are you comfortable giving combination endocrine therapy with CDK4/6 inhibitor rather than giving chemotherapy? Or are there special scenarios that you use combination endocrine therapy in the realm of visceral crisis?
So as you first, I want to say hi for all of you, and very nice to see you again, and I hope to see you in person in a very near future. And it's a very difficult question. Also, the definition usually is very elastic of visceral crisis or what is organ failure, which is what is the best to go. And I feel that it is important to weigh every case by case to have the decision to go for combinational CDK4/6 and endocrine treatment or to go for chemotherapy. As you know that usually we go for chemotherapy before, and we have now multiple trial going for this subset of patients in the region. We have a trial, what's called right choice trial, that we try to know it is better to go for chemotherapy or to go for hormonal treatment only. And I feel that it is important to weigh maybe in patient with postmenopausal patients, I usually go for combinational CDK4/6 with endocrine therapy, and maybe in premenopausal, I hope to go for more chemotherapy. It is not very clear to go for what is the best, but I think it must be like an MDT, going for a good decision for this, especially if we don't have a firm definition of the visceral crisis.
So Niti, what are your thoughts? When you have a patient with visceral crisis, is it always chemotherapy for you?
Actually, Dr. Hashim said it rightly that at least in premenopausal setting, I like to be more aggressive and definitely try chemo first, followed by hormones. But in a post-menopausal setting, I'll like to individualize treatment. I mean, in spite of meeting the stringent criteria of visceral crisis, that is either liver dysfunction or lymphangitis, carcinomatosis, classically meeting the criteria, even then in certain cases, I would still want to give hormones with CDK inhibitors.
Okay. So Dr. Mohsen, put your video back on and let's ask you the really tough question. Monarch E was just presented a couple of, I think a week ago, and we have the FDA approval for adjuvant abemaciclib in that high-risk group of patients with hormone receptor positive disease, and we're all going to start using it. There's no doubt about it. If your patient relapses after using abemaciclib. Now, this guideline obviously was just published a couple of days ago. Obviously, it hasn't incorporated, but we are now going to have to incorporate into guidelines. Are you comfortable re-challenging with a CDK4/6 inhibitor? Are you going to have some sort of a definition in the clinic that's going to help guide you as to what to do if your patient relapses after adjuvant CDK4/6 inhibitor?
I think Shahina, it would be like sort of coming out of experience with other things. So that 6-month barrier, definitely not. If a patient is on the CDK4/6 and then has stopped for more than a year, then definitely yes. And the ones that are in between, it depends on how lucky you feel you are that day with re-challenging with the CDK4/6. And especially if you're talking about, are we going to do next gen sequencing for them? So if you've got a PI3 kinase or a BRCA, then I'd be more entailed to use that, the PICRAE or the PI3 kinase inhibitor or the PARP inhibitor at that time rather than re-challenge with a CDK4/6.
Hisham, what are your thoughts here? Because this is a question that's going to come up in multiple forums since we've gotten the approval. We can't hear you.
So, Shahina, if possible to repeat the question because the internet was shutting down. So
no, it's the same question. If a patient relapses on adjuvant abemaciclib, are you going to feel comfortable re-challenging? Are you going to use a special definition to tell you when you're going to actually use CDK4/6 versus not?
it is a very difficult question now because we don't have it is like an expert opinion, so we can go for each challenge with CDK4/6. As Mohsen said, it is important now to go more deeply and assess the PI3K to know what is the best to go after abema, what is the time interval after this failure with the adjuvant treatment, what is the other circumstances. So it is like a multiple risk factor that we can choose what is the best to do. And we would go for adjuvant abema to have a very good response rate as to have a good outcome. So if we have a like direct failure after abema, I think we may go for chemo. If we have a more time, we can go for PI3K. If we have longer time, we can repeat everything. So I think the time factor is very important to assess the tumor biology of this patient. It is like actually hormonal sensitive, or it is purely non-sensitive because we gave the best ever treatment in the adjuvant setting.
No, I absolutely agree with you. I personally think when these patients relapse, the first thing we're going to have to do is actually re-biopsy because we know the biology changes under the pressure of CDK4/6. We'll need to determine biology. We'll need to determine those biomarkers, including HER2, PIK3CA, BRCA, the whole 9 yards. And then you're going to have to factor in when did the patient relapse? Did the patient relapse during abemaciclib? Did the patient relapse 6 months after, or did the patient relapse 1 year after? And I think depending on those timelines, that's how we're going to have to approach our patients. And we're probably going to have a consensus opinion about how and what is the most appropriate therapeutic strategy in those patients. But let me, yes,
say something.
Yes.
So
sure.
actually, I think, we have been very confused about liquid biopsies in breast, but I think this might be a very typical scenario in which we can find out that whether there's RB loss, which makes the patient resistant to CDK4 inhibitors, or there's any, not just PIK3, but is there any other pathway in the AKT track, AKT-P10 pathway, or of course, BRCA and PALB2. So, ESR1 positive. So this could be a very typical scenario in which we would also want to do, of course, a repeat biopsy, but a liquid biopsy to look for other biomarkers.
Oh, I completely agree with you. The only problem with liquid biopsy, and this is not only for breast, I think it's across all diseases, if you don't have a high enough tumor burden, you're going to miss 90% of those biomarkers. It's just not going to be captured. And then you have the added fact that, liquid biopsies, the cost is also there. That's huge. While I think the cost of all NGS is huge right now. And I think companies will have to scale back on the cost if we're going to use it more appropriately at multiple time points. So I wonder if the group will allow me, since I'm such an opportunist, to not only talk about the metastatic setting, because it's the early stage setting that's also become, very, very interesting. Now, before I ask the question that will relate to the metastatic setting, let me ask you a question of early stage setting. And I go back to Dr. Mohsen because he keeps switching off his video, and I'll keep making him put on his video. In the early stage setting, high risk hormone receptor positive patients, hormone receptor positive, HER2 negative, BRCA mutation positive, what are you going to use in that adjuvant setting? Are you going to use abemaciclib, or are you going to use olaparib in that early stage setting?
I'd probably say the olaparib rather than the CDK4/6. I think the data is better, and personally, I think that having it as a target and a target that you've measured, so you've got a marker for that drug, I think that's the best. And as you're always saying, as an advocate for the PARP inhibitors, Shahina, you always say use them. The earlier you use them, the better you're going to get the results out of them. And I keep switching off my video because the internet is not that good, so that's why I keep switching off.
So, Neeti, let's go to you. So, what if you did start with early stage breast cancer patient? You gave adjuvant olaparib. You've completed 1 year, but that patient was a young woman, had 17 lymph nodes positive. Would you consider sequencing olaparib with abemaciclib?
No, I don't think I'll consider sequencing, although there's a high risk case, but I will try to reserve some options for later, because it's very likely a scenario in which she may relapse. So keeping some options reserved will be an option. And olaparib beyond one year may also be very tricky, because she'll already be having anemia and probably transfusions. So it's a very difficult call. But yes, I like to use other options for later.
All right. So let me go to you, Hisham. A question that I'm always asking everyone. Are you comfortable in the metastatic setting if a patient has a PALB2 mutation to give olaparib or talazoparib for that matter? It doesn't matter which PARP inhibitor you want to use?
Yes, I completely agree to go for this. As Mohsen just said, we and you personally usually fan of PARP inhibitors, and yes, I think we can go for to use for talazo or olaparib in this case.
Okay, so I see Christian has joined. Hi, Christian.
Hi everyone. Hi Deborah. Thank you for sneaking in. I was actually stuck in the FIGO meeting, which is virtual today, but it brought me from Sydney now to India. So I'm happy to be with all of you.
So let me pose a question to you, Christian. As we know, we're talking today about hormone receptor positive metastatic breast cancer. And one of the questions has come up. Now we have 2 guidelines that have been published in the last year. In July, we had the ASCO guidelines, and then we have the ESMO guidelines that have just been published. And one of the questions that repeatedly comes up in a patient who has a BRCA mutation, do you use a CDK4/6 inhibitor first, or do you use a PARP inhibitor first? And if you look at the guidelines for ESMO, they've actually given you the opportunity to use a to use a PARP inhibitor in that second line setting, even if you have a PIK3CA mutation. But interestingly, when you go to the ASCO guidelines, it says if you have a germline BRCA1, BRCA2 mutation, oral PARP inhibitors monotherapy may be offered in the first line through to the third line. Now, what are your thoughts about this?
Yeah, that's a $1 billion question. And the issue is usually in our country, we go usually first with a CDK4/6 combination. And all these guidelines with options and options and options are for us more a suggestion then that's really to follow step A, B, C, D. So if I have a woman, to be very honest, who has never been exposed to a PARP inhibition, but she failed endocrine treatment, and that's the reason why you were asking that question, I would switch to a mode that this woman never had seen before, or not the tumor, sorry, not the woman, the tumor. So I would definitely go for the PARP inhibition in these cases. The tricky part is that the PARP inhibition is not a non-toxic treatment. And we are just a little bit it's an most easier way as we learn to deal with the CDK4/6 inhibitors to use them. But if you go back to the big old textbooks of oncology, they are telling us that whenever you have the chance to use a different mode of action, try to go for it. The issue is, what we have all the time is if you have a new drug, then the sequence is the next question. So if your first 5 patients with PARP inhibitors are running smoothly, I think you're emotionally more on the PARP way than on the CDK4/6. So we have the same issue with our AGO guidelines. And if you then aspect in a real world, then PARP is a little bit on hold, as someone just mentioned, I will keep something on stock until it matters. I think it's going to be a really big question if we ever find these data, to switch those options. But I think it would be, maybe it's a good point here that I give my presentation to have a flow, and I definitely, from a specific reason, didn't put in the PARP inhibition because it's spreading out it's kind of losing the real endocrine world, and it shows us that maybe we might discuss this when I'm done. If we just have the idea that the PARP inhibition is for triple negatives and endocrine sensitives. So that's a cross link here, which is very interesting to be discussed. So if you don't mind, I would share my screen.
Yeah, sure. I mean, from my side, I think they're going to ask you to give your presentation, by the way, after this. But just another point that I wanted to discuss with you. If you look at the Collins paper that looked at data from the Flatiron database of patients who had received CDK4/6 inhibitors in that real world database, when you looked at the progression-free survival and the overall survival amongst patients who had a germline mutation positive disease, their PFS and OS was almost half of that of patients who had wild type disease. And then you had Professor Park's trial that was presented at ASCO this year, where she prospectively looked at patients who received palbociclib and endocrine therapy in that sensitive setting. And again, she showed PFS was half in patients with germline mutation positive disease, really suggesting that yes, CDK4/6 inhibitors are working, but they're not working as well as in the wild type. So should we be using PARP inhibition earlier on? And would love to know your thoughts about that. I know you have a screen that you want to share. More than happy to hand it over to you.
Okay, but this is definitely one of the very important questions on the molecular management of breast cancer. So if you have this information, and in an ideal world, you would love to have all these data up front, but we don't have it. Maybe we could discuss it then. So I tried to get my screen running here. And
so maybe you can start with your talk. I think we're done with the panel discussion, right, Rajesh?
Okay, good. Anyway, whatever questions are coming up, we are all happy to take it. So first of all, I have to express my appreciation to be involved in this really prestigious meeting. And you're just going to see this from the labels, what's going on here, that the ASCO CEO and all the other people who are just influencing breast cancer over decades, I have to say, are involved in this program. So of course there are some disclosures I might to share, but they're never touching my presentation. So first of all, it's very important to understand that I'm the only gynecologist here in this arena, as we in Germany treat breast and ovarian or gynecologic cancer, the surgical part and the systemic treatment as well. And we have touched that we are talking about the majority of breast cancer cases. So endocrine treatment of breast cancer will never ever be a boring issue. And as we just heard from the discussion, it is just cross-linked with all the other subtypes. And if you go back in the 70s, tamoxifen as a selective estrogen modulator was the first one transferred from fertility medicine into breast cancer scenarios. So that's something what some of the younger doctors do not have in mind, where tamoxifen came from. And then there was a quiet period of 4 decades until new endocrine therapies have really settled in the field of hormone-sensitive breast cancer. And the biggest problem is, even if we have a targeted treatment, we know the target, we know the drugs, we know all the pathways, we have a big problem in the clinical setting on the endocrine resistant disease. So the question that you have discussed already are the new drugs. Then the crucial clinical question is, when switching to chemotherapy. So if we go back a couple of years, metastatic breast cancer, even in the ER positive, was the domain of chemotherapy. And most of the medical oncologists have to really improve their performance to getting rid of the chemotherapy, and offers the field of endocrine treatment in the first place. So having said that, we have some very interesting new pearls on the field. So the Pearl trial and the Young Pearl trial asking exactly that question. And you can argue over hours if capecitabine is the right chemotherapy to compare here, but it's a principle that has been asked here. And then finally, how to come endocrine resistance, to recycle actually endocrine sensitive drugs. That's an issue for the therapeutic landscape in the future. So I'm sure you all have discussed this, and we have actually a very good start in these days in screened population environment. Most of the cases are in early stage, but even those are relapsing. About 30% of these are jumping into the metastatic breast cancer. And every time I just display this slide, it's unbelievable that Sir George Beatson was actually one of the founders of endocrine treatment. He had no idea how a drug works. He had no idea how a receptor would look like. He had no idea about the interactions, but he had a mission. And then based on these cases, he was developing the endocrine treatment, and everyone knows the fundamental changes about all those new drugs we are using here without any question. But if you sort these data and these drugs into our armamentarium of these days, you're going to see that in the endocrine treatment, ovarian ablation still is an important issue, more than ever in the adjuvant setting, when we're going to treat the young premenopausal woman, depleting fair-field estrogens. This is what the aromatase inhibition is doing, and I think none of the three tastes are very different. We have seen tons of trials comparing each other. There's new music in the field of the SERDs. Some oral available drugs are on the horizon. mTOR inhibition has a renaissance, actually. Then, based on the availability, the PI3CA inhibitors, bopalizib and alpelisib, are on the market. And as Dr. David just mentioned, the PARP inhibition as a cross-link coming over from triple-negative breast cancer to play a certain important role in the endocrine-sensitive breast cancer. And then chemotherapy, when all those drugs have been used, we are not able to reactivate or get back to a sensitive environment, then chemotherapy still is an option in this treatment, but it has been postponed. And some of our patients with endocrine sensitive metastatic breast cancer, they don't see chemotherapy that early. So let's flip back for a second to the early breast cancer, because this is a not pre-treated environment. This is a busy slide, but I quickly walk you through this. This is what I call the management of metastatic disease. You see here on the far left, the subtypes, luminal A, B, HER2 enriched, triple negative, and whatsoever. And then you're going to see here in the top layer, the somatic non-silent mutations, the truncated mutations, missense mutation, and whatsoever. If you keep that in mind, you understand that even luminal A breast cancer is not a homogeneous disease, and luminal B and HER2 positive and basal-like breast cancer, they travel with an intrinsic increased risk of recurrence. That's the most important information that we take away when we talk about management or molecular management of breast cancer. So that paper from Angus and co-workers in Nature Genetic is very interesting, because what you're going to see here is the subtypes, the endocrine sensitives, triple negatives, and HER2 positive disease. And the top 5 or 4 mutations, either in the early breast cancer or in the metastatic breast cancers, which is the light blue and the dark blue column, are just exactly the same. So you don't need that much at the moment, but these are the ones you would like to have very early on when testing is not a financial toxicity on its own. So if we then flip back in clinical routine, there are 2 issues which are very important. The Lobezo paper that has been published in Annals of Oncology in 2016 is picking a subset of patients, showing that patients with, and we are talking about endocrine sensitive breast cancer here, patients with initial endocrine therapy have a much better overall survival than those who are instantly or reflective treated with chemotherapy. That's one issue. And then Dr. David just mentioned that ESMO guidelines and ASCO guidelines, but they are just merging into one issue, that endocrine therapy is the preferred option in patients with endocrine sensitive metastatic breast cancer. And then there's the saying, except visceral crisis. But based on the new data we have here, especially in the CDK4/6 inhibitors and all the new drugs, the definition of endocrine crisis gets a little bit vanishing on the horizon, because there are only little endocrine or visceral crisis. And the issue is chemotherapy in this issue really the best part? So this is something what Fatima Cardozo and the consensus meeting in Lisbon, which is coming up in November this year, we have to pay big credits. They do the same efforts here in the metastatic breast cancer to come up with a common sense compared with the early breast cancer meeting in Switzerland, in St. Gallen. So I think everyone is clear here that whenever it's feasible, endocrine treatment is perfect, but we do not have a testing here if the drug then is working, other than we can test the receptor. So that will be a long story about CDK4/6 inhibitors in the first line setting. And I think every one of you knows that the 3 different flavors are having great data: Paloma, Mona Lisa subset, and the Monarch issue. And we have seen there that this is really standard of care. So an endocrine monotreatment on its own without a CDK4/6 inhibitor is not standard of care. And then there is some good news, and that is that it could be transferred in the premenopausal setting that has been shown at one of the latest big meetings, had been published so far, and the Mona Lisa 7 trial has shown that ribociclib and fulvestrant versus placebo and fulvestrant and ovarian downregulation in premenopausal women is, in the first line setting, something we can use. There's the most recent update from Dennis Lehman published in Annals of Oncology, and these are robust and solid data. Then in premenopausal women as well, the combination of CDK4/6 inhibitors is improving overall survival. So then another recent update from the MONALEESA-2 trial from Gabe Hortobagi from this year's ESMO is showing then for the MONALEESA-2 data, the improved statistically significant overall survival in this setting. And it's showing, and this is so important for all of us, that this is a long-lasting effect, though it's not a fluke for a slide where you just see an effect. These are really clinical data you can rely on and build your clinical subset on that. And most interestingly for me, and I think this is the same what you guys share with us, is that you postpone chemotherapy for more than a year. And this is a real benefit. And I can recall my very first patient, it was close to Christmas a couple of years ago, was really a fatal lung disease from breast cancer. And I was just asking myself, hey, Chris, you're giving this presentation, then the patient sitting in front of you, would you go the chemotherapy road or you believe in the data? And I did it. And it was a quick relief on the symptoms. And she was celebrating a nice Christmas with her family. And that is the convincing part which travels along with these data on a long-term follow-up that we can rely on that. So the next issue then is what's going on in the second line setting. And this is a busy slide, and you're going to see that all those agents used with fulvestrant are positive. Even mTOR inhibition, aromatase inhibition, the Bolero-2 trial in the postmenopausal setting is giving us a hazard ratio of 0.43. And then in those who are resistant to that, that is the PIK3CA mutation subset in fulvestrant, the SOLAR trial, again, in postmenopausal women and men, interestingly enough, you're going to see really consistent evidence of how you sequentially can proceed with your treatment. And the issue I touched in the beginning was the endocrine resistant, and from the Paloma-3 trial and the Paloma-2 trial, both dealing with fulvestrant in the second line setting. There's significant difference in the two data sets, but you're going to see there is a huge amount of resistant, 78% versus 38% resistance to endocrine treatment. And this is something which is traveling with us all the time. And another issue is just, I want to show this briefly to you, and this is really in line with what I touched right now, is the update on the Paloma-3 and Monarch-2 trial. So Christopher Fanelli showed this in ASCO 2021, palbo plus fulvestrant versus palbo and, versus fulvestrant and placebo. You're going to see there is no, in the subset, no primer chemotherapy in advanced breast cancer. There is a difference. When you use it after chemotherapy, again, the sequence question, there's not much benefit. But George Schlett actually published in JAMA Oncology, Monarch-2 trial, and you're going to see here very nicely the primary resistance and the secondary acquired resistance. So this is an issue that as early as possible, you might use these data to have the full benefit of these data, and don't wait until with a combination here of abemaciclib and fulvestrant until there might be a secondary resistance. The data from Fabrice André on the SOLAR-1 trial is touching the point I touched earlier, is the molecular management. So the minute you have the minute you have a metastatic disease in endocrine sensitive breast cancer, at least in our practice, we try to have information of PIK3A mutation. We like to have information of the PARP inhibition, and that's enough for the moment to plan our treatment. And you're going to see in the PK3CA mutated cohort the tremendous benefit of alpelisib and fulvestrant, which is not shown in the wild type scenario that has been pointed out by Dr. David earlier. And that's a slide here. I just want to show this waterfall plots to you. This is the PIK3A mutation cohort, and you're going to see all those positive treatment options. And then here, this is a wild type cohort, and that looks totally different. So this is a very interesting paper that you might read if you are interested in this field here. So what is the management on the CDK4/6 inhibitors? I think the important issue is for everyone, if you deal with this is not an oral form of chemotherapy due to the neutropenic events. That's a miscommunication from the early beginning. So I use the phrase of an individual dosing, which is linked to the bone marrow reserve of an individual patient. And you're going to see this in Paloma 2, MONALEESA 2, and Paloma 3. In all those trials, you're going to see whatever combination you use, that the neutropenia as an individual momentum has to be taken into consideration to come up with the perfect dosing to maintain the treatment on a long run. And also monitoring and prevention of other side effects which are linked to compliance and to the adherence are very important. And it is, first of all, diarrhea. It could be the hepatobiliary toxicity, cardiac toxicity. I'd have to be very honest. I have never seen QT prolongation in my ribociclib patients. Neutropenia, I was just mentioned that. VTE is an issue which is linked to abemaciclib. Pneumonitis and diarrhea is common, the common trunk for all these drugs. And I think that's a perfect moment to just let people know that's a team play here. The nurses, the patients, the families should be involved to prevent that, and also to know when to stop it until you see your doctor or your nurse to have a new plan on that. So usually on a Friday night, when the diarrhea occurs, the patient has to understand, stop it, take loperamide or whatever prevention treatment is traveling along with the label in your country, and then that's a good way of doing it. All these drugs need a monitoring and need a proper education. Dose modification is better than any drug holidays. This is a little bit linked to how the drugs are on the market. Some of them are easy to de-escalate. Some are a little bit tricky on doing this. But if you keep that in mind, it's an issue if you're going to start with a full dose or if you would like to escalate or de-escalate. I think this is something we might discuss at the end. Avoid the concomitant use of strong CYP3A4 inhibitors and inducers. Ask for the medical co-medication history, and if you're going to do this, you're fine. So then the typical question is, what are we going to do first? Fulvestrant or palbociclib, or letrozole and palbociclib? That has been in length studied in the Parsival trial. You're going to see here the primary objective of progression-free survival. There's no big difference after 32 months. You're going to see a little difference in visceral versus non-visceral disease. But as we are just discussing, the train is moving forward with new drugs, new combination that has been discussed with you early on. So that's a question I raised here earlier on, chemotherapy versus optimal endocrine treatment. Just to give you an overview on that, Dr. Park has shown this at ASCO 2019 and has been finally published in the Lancet Oncology 2 years ago. And you're going to see here progression-free survival in the young women having the capecitabine versus exemestane and palbociclib plus ovarian downregulation. So there is a benefit for the endocrine treatment, and that is what all the guidelines are recommending. And then the Pearl trial, Dr. Martin has published this recently in Lancet Oncology, 2 different cohorts. You're going to see the cartoon of the treatment here, and then you see that there is no benefit in that trial. There's no misadvantage for capecitabine or the endocrine treatment. It's a non-inferior issue. And you're going to see that you might need here down in this little cartoon information on ESR1. That is one of the drugs you might, or one of the genetic informations you might have if you consider yourself on endocrine treatment and or the selection which treatment might be best. So that's the open question. Maybe you have some answers on that. What are the reasons for treatment failure? Is this a lack of efficacy, or is this really endocrine resistance, and where in this downstream pathway the endocrine resistant might be? There are different definitions out here. Again, credits to Fatima Cardozo to bring it in a nice and easy to understand way how to do it in the adjuvant setting or in the metastatic setting. So what we really know is that endocrine resistance, if you are on treatment, that's not very good information. Then you might go, what Dr. David was just asking the question, if you have PARP information, go that way, or have an idea on the sensitivity, why a drug is working much better in wild types or in the mutation subset of a given population. So these are all very crystal clear information gaps. What is unclear is a slide which is busy like this one. These are the very different ways of overcoming endocrine resistance. Some of the drugs we just mentioned, some of the drugs are subject for new trials, phase 1, phase 2 trials. Combination, I think combinations that we cannot combine until the very end, because the toxicity in all the downstream mechanism will not allow us to use this in late line endocrine treatment in metastatic disease. But again, this paper needs to be read because there are very nice data in that. So the clinical pathway of IE naive, IE resistance, indolent disease, we have some thoughts here that we could put into practical guidelines. The question is, how many options do we have to let your patients participate in early phase 2 or 3 trials with the new drugs? That's depending on your environment, but regardless where you're working, I think 3 or 4 drugs, which are mostly available globally, are helping us a lot. In our country, the AGO guidelines, we have to try, well, we try to put this in algorithm to make it easy to understand pre- and postmenopausal women based on the adjuvant pre-treatment, tons of options. You see the new drugs here, CDK4/6 inhibitors, ovarian downregulation, combination. In some parts, it could be endocrine treatment in late line, but the new strategies are shown here. And you're going to see PARP inhibition very early on. There is chemotherapy in endocrine resistant, and we have defined then progression less than 6 months. Endocrine sensitive, we're going to see the evidence here based on the combination plus everolimus, alpelisib, whenever it's available, and 40% mutation. That's really a solid piece of information. So having said that, once again, I have to apologize for my delay, but I hope you will find actually now a good overview over the possibilities of treating endocrine sensitive metastatic breast cancer. And having said that, I'm going to stop and thank you for your attention.
Dr. Christian Jakesh, thank you very much for taking time out of your busy schedule and enlightening all of us. And it is my pleasure to share with you that we have 1,100 delegates registered for this meeting from over 40 countries. Kalpesh, do we have any questions for Dr. Christian? If no, then we can move to our poll. I would also like to thank our moderator, Dr. Shahina Daoud, and Dr. Niti Rajada, Dr. Ada Bonedar from Algeria, Dr. Mohsen, and Dr. Hisham for covering this challenging topic so nicely. Now, delegates, my request to the delegates, you have poll question on your screen popped up. In case because of your Internet Explorer setting, it is not popped up, you can click on the poll button and you will see the poll. The question is, do you see role of androgen receptor inhibitors in the treatment of triple negative breast cancer patients? Choices are yes or no. Here you go. You can submit the send button as soon as you are done, and then technical team will show the responses on screen. And here we have, so we have majority, 3/4 of the people in favor of yes, and 1/3 of the people in favor of no. So next question, please. So what biomarker testing do you recommend in your majority of advanced triple negative breast cancer patients? G, BRCA only, A, B, PDL1 only, C, GBRCA and PDL1 both, C, none of these. Access to test is a concern in your area. So here we go. You need to choose A, B, C or D and then push send button. It is this polling is available only on the delegate portal where you have logged in. It is not on the faculty portal. So technical team can display the results. So majority have gone for both GBRCA and PDL1. It's 72.73%, and 18% have reported that none of these, they do not have access to the test there in the country. And with that, we go to invite Dr. Nadia Herbeck from Germany. Dr. Nadia Herbeck is full professor at Ludwig Maximilians University, LMU, and head of breast cancer at LMU University Hospital, Munich, Germany. Dr. Nadia is recipient of ESMO 2020 Lifetime Achievement Award and author of more than 500 peer-reviewed publications. We had an opportunity to hear Dr. Nadia on several occasions, and I hand over to Dr. Nadia.
Thank you very much for having me at your meeting today, and thank you for your kind words for introduction. Let me just see. So I hope you can see the screen now and everything should work fine. Is it okay?
Yes, it is okay. We can go.
Okay, perfect. So my topic is a little bit a switch from what we've just heard so elegantly by Dr. Jakic, is now the triple negative breast cancer. And I'm going to talk about early and metastatic disease and the recent guidelines. So here are my disclosures. So I will touch on current therapeutic standards in early and metastatic triple negative, talk a little bit about the role of immunotherapy, the biomarkers, and we see that availability may be a big issue, and we can discuss this afterwards. And we have a talk about PARP inhibitor, new registrations, guideline recommendations, and then hopefully we can address the open clinical questions. So let's start with the early disease. So it's actually very easy. We need ERP or HER2 as a biomarker in order to define triple negative disease. And then we will need germline BRCA testing in high-risk patients in order to look whether there is an indication for PARP inhibitor. If you look at early triple negative disease, this is from the Munich Cancer Registry. We can see that these tumors have the worst prognosis. This is patients coming in with primary breast cancer, over 30,000 patients here in the Munich area. You can see that they have the highest risk for recurrence, the worst survival, and on the right-hand side, we can see that they actually have the most relapses and the most metastases. So our current standards in early triple negative disease are neoadjuvant therapy, and this is from a recent ASCO presentation when a meta-analysis, almost 30,000 patients, showed that there's actually quite a good impact of PCR on outcome in triple negative disease. And that is one of the reasons we recommend neoadjuvant therapy. The other one is that we can now modify therapy according to PCR standards. So it's not just that we know what the prognosis is, but we can actually help patients similar to the HER2 positive setting to improve their outcome. The standard chemotherapies include anthracyclines and taxanes, but we sometimes have patients who are too old to have an anthracycline, or patients with a subsequent contralateral triple negative breast cancer who've already been pre-treated with an anthracycline. So I just wanted to show you that there's also some data on avoiding anthracyclines in patients where you want to do this. This is from a combined analysis of 2 German trials, large trials, about 6,000 patients. And we gave 6 cycles of TC, docetaxel, cyclophosphamide. And you can see here that that's actually quite similar in efficacy in the early stages on the left-hand side to an anthracycline taxane sequence. On the right-hand side, we can see that if you have really bulky lymph node disease, locally advanced breast cancer, obviously anthracyclines must be given. And there's also data from a small US trial, which I included because not everybody knows it, given docetaxel and carboplatin. It's called NeoStop trial, and the authors saw similar efficacy and outcome for 6 cycles of docetaxel carboplatin to an anthracycline taxane carboplatin sequence. So I'm not arguing to avoid anthracyclines. I'm just telling you in those cases where you need to, there's actually a good evidence that you can do that. Then the question is, can we improve on the taxane? And here's data from the German Gepacepto trial showing that actually with nab-paclitaxel, there is better outcome, in particular in triple negative disease. There is more PCR and also better outcome. The question that sort of is interesting from an international standpoint and led to a lot of discussion at St. Gallen earlier this year, last year, was the question about the platinum compounds, where we can see that it increases PCR. We've seen this in the German trials, as well as here in the Brightness trial on the left-hand side, and also in the trial by Bill Sykov and colleagues from the US. But so far, we did not know whether it also improves outcome. What we do know is that the impact on PCR with the addition of carboplatin is independent of the BRCA status that you can see on the right-hand side. Even the wild-type tumors have a better impact. That is due to the fact that platinum, G-BRCA mutation carriers have very chemosensitive tumors, and you don't see the incremental effect of the platinum so much. But now with the data by Dr. Leubel and colleagues from ESMO this year, from the Brightness trial, we can now safely say that platinum, in addition to an anthracycline taxane sequence, does improve outcome, whereas veliparib as a different PARP inhibitor in this trial actually didn't add anything. So, and then what we do after non-PCR, there is data from Japan that we can add capecitabine 6 to 8 cycles, and that actually improves survival in patients with non-PCR in HER2-negative disease, and the majority of the effect comes from the triple-negative cohort. So that is our standard so far, anthracycline taxane sequence, and in patients with non-PCR, we add capecitabine. There is now consistent data that immunotherapy is effective in increasing PCR. We know this from the Impassioned 031 trial with atezolizumab and the nab-paclitaxel containing regimen, and from the Keynote 522 study, which included paclitaxel, platinum, and anthracyclines as the chemo backbone. And the interesting thing is that both studies show that the impact of immunotherapy does not depend on the PD-L1 status. So there is more efficacy overall also of the chemo in the PD-L1 positive population, but the incremental benefit from immunotherapy does not depend on PD-L1 status in early breast cancer. Here's the Keynote 522 study again, because it led to the approval of pembrolizumab in this indication in the US. And we also had a nice discussion with Peter Schmidt and Lisa Carey at ESMO earlier this year. So again, this is the best possible conventional chemotherapy backbone, anthracyclines, dose then carboplatin and paclitaxel and pembrolizumab. And pembrolizumab was also given in the adjuvant phase in a placebo-controlled fashion. What we did see at the interim analysis earlier this year in an ESMO virtual plenary was that outcome is improved by pembrolizumab, not just PCR, but also outcome here by almost 8% and a hazard ratio of 0.63. So very important impact. And like Peter discussed so nicely at ESMO, most of these events were distant relapses. We also had an exploratory analysis which was also included at the ESMO discussion, and we see that patients with the PCR do not benefit from the addition of immunotherapy regarding EFS versus the patients with non-PCR who received immunotherapy actually did better. We don't know why this is so. We have no idea whether the adjuvant component is actually important, because their data like the Japan-Nervu study only gave a checkpoint inhibitor in the preoperative setting and also had a very nice effect on outcomes. So a lot of open questions still. And there's also more data to be expected from atezolizumab. First of all, the outcome data from Impassion 031, which will also help us to understand whether we can combine IO with capecitabine in the setting, because it was not placebo-controlled in the adjuvant phase in the Impassion study. And then there is another neoadjuvant trial looking at paclitaxel plus atezolizumab, as well as a purely adjuvant trial, Impassion 030. The other important data in early triple negative disease is data from the Olympia study, where we saw that patients with triple negative disease, either with non-PCR or if just treated in the adjuvant fashion with tumors larger than 2 centimeters or node positive, received olaparib for 1 year versus placebo. And you all know the results. There was a strong effect on invasive disease-free survival with a hazard ratio of 0.58. So very, very clinically meaningful. And in our country, this has led to off-label applications for gBRCA testing in those patients that don't fulfill the German testing criteria. To begin with, would mostly be the luminal cohort in Olympia. So the summary of the early breast cancer part is that neoadjuvant chemotherapy here is standard in triple negative disease. Anthracyclines and taxanes are the substances we should use. We do have some anthracycline-free options if there is the need to give them. Nab-paclitaxel has very strong data, but I realize it's not available in every country in this setting. And platinum is an inexpensive drug that can be added easily. It increases PCR, and we now know, I think for sure, that it also impacts patient outcome. PCR is correlated with favorable outcome in patients with non-PCR. So far, we tend to escalate therapy with adjuvant capecitabine. The data from the Olympia study suggests that 1 year of olaparib is helpful for patients with a BRCA mutation. And obviously, given the neoadjuvant setting, we need a risk-adapted interdisciplinary management for these patients right from the beginning. With regard to immunotherapy, there is quite consistent data for pembrolizumab and atezolizumab. PD-L1 status is not predictive, and the addition of immunotherapy improves PCR. And since Keynote 522 with a different study design already was able to show that also outcome is improved, there is FDA approval now, and we're able to use this drug in an off-label setting in some very high-risk patients. But I think with regard to immunotherapy, we have many, many open questions. Who are the patients who definitely need it? Can we do a chemo induction and see whether there will be PCR even without immunotherapy? What's the optimal chemotherapy backbone? What's the contribution of the adjuvant versus the neoadjuvant setting? And how does this interact with other escalation therapies like olaparib or capecitabine? So the metastatic triple negative disease, again, we define the disease by ERPR and HER2, and then we need the GBRCA status because PARP inhibitors here are approved, talazoparib and olaparib, because they are advantageous versus monochemotherapy. And then we need to measure PD-L1 status right from the beginning up front, because in first line, we have approvals now for atezolizumab plus nab-paclitaxel in the Impassion 130 study, but also very recently the European approval for pembrolizumab based on the Keynote 355 study. And then obviously there is the FDA approval for sacituzumab, and this will hopefully be available in Europe even before the holiday break, because there was recently a positive opinion at EMA. So in the metastatic setting, again, this is a very high-risk disease. We can see again on the right-hand side data from the Munich Cancer Registry, where the outcome in triple negative patients has not improved over time. You can see patients treated before 2010 had similar worse bad outcome as patients treated after 2008. And on the left-hand side, you can see that there's also specific recurrences that are particular for triple negative disease, so that patients get early visceral metastasis as well as brain metastasis. Again, here's a consistent data for checkpoint inhibitor therapy in the first-line setting. Impassion 130 showed that nab-paclitaxel plus atezolizumab improved overall survival, although this was an unplanned descriptive analysis, but the clinical benefit is quite impressive. And on the right-hand side, we can see the first publication of the Keynote 355 study already showing that pembrolizumab with a variety of chemotherapies is able to improve PFS. And we've just seen data at ESMO that it's also impacting overall survival. Here's the Impassion 130 study again with the updated analysis from ESMO of last year, an overall survival benefit of about 7 months in median in the PD-L1 immune cell positive population. And there is evidence that we can measure the PD-L1 status in the primary tumor as well as in the metastatic tissue. But you should be aware that some metastases are not so immunogenic. So liver tends to have lower PD-L1 positivity than other organs. So I would suggest if you have a liver met and it's PD-L1 immune cell negative and you want to use atezolizumab to check in the primary tumor as well. There was recently very conflicting data from the Impassion 131 study looking at paclitaxel plus atezolizumab, where we did not see an improvement in PFS nor in overall survival. So for the time being, because this confirmatory study was negative, the FDA revoked the preliminary registration, or to put it the other way around, Roche withdrew its application for a preliminary registration, and but in Europe they maintain the full registration based on the Impassion 130 study. The reason the FDA suggested to withdraw the registration was that the Keynote 355 study had now presented also overall survival data. So there was no need anymore to have these preliminary accelerated registrations because there's now full registration in the first line setting. And as the Keynote study has a confirmatory study, they went for full registration. And the Keynote study, Keynote 355, is the first line setting looking at pembrolizumab plus a variety of chemotherapies, paclitaxel, nab-paclitaxel, as well as carbo-gem in a placebo-controlled fashion. And we saw that this prolongs progression-free survival, and the impact is most pronounced in tumors with a CPS score of 10 and larger. And now recently we saw for the first time that this also improves overall survival in a quite meaningful way with a median difference of about 7 months, which is interestingly just in the same ballpark as the difference in the Impassion 130 study. Looking at the subgroups, we see that pembrolizumab here gives us more flexibility. It works with both taxanes. Doesn't seem to work so well with carbo-gem, but this data may be biased because they also used carbo-gem, particularly in patients with a very short disease-free interval of 6 to 12 months. So this may be biased because these patients seem to be very hard to treat by any therapy, and this is also true for immunotherapy. For patients who did not have the chance to get a checkpoint inhibitor in the first line setting, there is interesting data from later lines here, the Keynote 119 study, which ran pembrolizumab against monochemotherapy. And we see that the study did not reach its primary endpoint because there doesn't seem to be any difference in tumors with a CPS of 1 or 10 and greater. But if you look at tumors with a CPS score of 20 and greater, we see that pembrolizumab seems to be better regarding survival than monochemotherapy. So this could be for those few patients who did not have a chance to get an immune checkpoint inhibitor in the first line study, this could be the rationale to use this in a later line setting versus monochemotherapy. Recently, we've also seen another approval based on the ASCENT study, which is a phase 3 study looking at an ADC, sacituzumab govitecan, versus treatment of physician's choice with the primary endpoint of PFS in patients with 2 and more chemotherapies for the advanced disease setting. Sacituzumab govitecan is an ADC with the chemo payload being SN38, and it's a humanized anti-TROP2 antibody. And I just have to show you one curve to show you why this drug was approved. There's a significant and clinically more than meaningful overall survival advantage compared to treatment of physician's choice with this variety of monochemotherapies, hazard ratio 0.48 in the with the median overall survival here of 12 months in the sacituzumab arm. San Antonio last year, Sarah Hurwitz presented data looking at biomarker expression, and we see that there is no impact of TROP2 expression on efficacy of sacituzumab, so it was approved without a companion diagnostic. Another therapy that we should always keep in mind is the PARP inhibitors. We have 2 positive phase 3 trials, Olympiad as well as Embraca, for olaparib and talazoparib, showing that these drugs are better regarding PFS than monochemotherapy. And they also have very good quality of life data showing that patients actually do better under the PARP inhibitors, which is also the more effective therapies. There is some intriguing subgroup analysis here from the Olympiad study looking at olaparib in different lines of therapy. And you can see on the right bottom side that if olaparib is given before any chemotherapy, then they actually saw an 8 months median overall survival advantage, which is quite intriguing. So it seems to be, and we've discussed this also before in the luminal breast cancer session, that if you give the PARP inhibitor, you should give it early. If you've run out of therapeutic options, there is still chemotherapy. In Europe, we also have the approval of bevacizumab plus a taxane or capecitabine in the first-line setting. And then there's a variety of monochemotherapies, but there's no particular chemotherapies for triple-negative disease, except for platinum, which in our country is mostly given in the neoadjuvant setting. So it's probably not so effective to reinduce platinum in the first-line setting. And with that, I just want to summarize the metastatic part of my talk. Chemotherapy is our backbone in metastatic triple-negative disease. We should know for the first-line setting the PD-L1 status of the tumor and add immunotherapy if PD-L1 is positive. There is 2 approvals, depends on availability. In Europe now we have 2 approvals for atezolizumab and pembrolizumab, and in the PD-L1 negative cohort we have an approval for bevacizumab, which improves PFS but not survival. We should think about the germline BRCA testing, which mostly in triple negative is done already in the early breast cancer setting, at least up to the age of 60. It's a standard in our country and in several other countries as well. And PARP inhibitors improve PFS versus monochemotherapy. And for second-line therapy and beyond, sacituzumab improves overall survival versus monochemotherapy. And we expect to have a European approval very, very soon. I did not specifically comment on the molecular subtypes like your first polling question asked about the androgen receptor, because they do not, at least yet, translate into clinical therapeutic consequences. There is some data on androgen receptors, but the companies have all halted their development of the respective drugs. So it's not a standard option in metastatic triple-negative disease. And I think particularly for these patients, clinical trials are always the best option. And with that, I would just like to highlight also the new ESMO guidelines, which we worked really hard on of the last half year to have them out by the ESMO meeting. We did not manage that quite so well, but a couple of weeks later, now they're online in Annals of Oncology, and we're just putting in the final touches. That is Dr. Gennari mostly, and it's been a pleasure to work with all the colleagues in the authorship on these guidelines. And I think they're very modern. They reflect access issues, but they give us the backbone in an interdisciplinary fashion of the new therapeutic standards. And for triple-negative disease, they again highlight the fact that we need to know PD-L1 status, gBRCA mutation status, in order to make appropriate treatment decisions. And with that, I would just like to thank you all for your attention and happy to take part in the discussion as well.
Thank you very much, Dr. Nadia Harbeck, for the very nice informative presentation. Before I invite Dr. Shyam Agarwal sir to moderate the panel, I would like to announce that on the delegate portal, you have an option of feedback where delegates can give the feedback and download the certificate of the meeting. Those who have missed the meeting on last Saturday on 16th October, they can have they can attend the proceedings and interesting sessions on our website, miceideas.in/past meetings. So with that information, I would like to invite Dr. Shyam Agarwal sir. Dr. Agarwal is Chairman and Director, Department of Oncology at Sir Gangaram Hospital in Delhi, very, very prestigious hospital in India. And with Sir Dr. Nadia Harbeck is joining us in the panel. And along with Dr. Nadia, we will have Dr. B. Ramos from Philippines. Dr. Ramos is medical oncologist at Chong Hua Hospital from Philippines. And Dr. Ramos is outgoing president of Philippine Society of Medical Oncology. With him joining Dr. Mastura MD Yusuf from Malaysia, Dr. Mastura is Head of Oncology Services at Antai Hospital and Consultant Clinical Oncologist at Sime Derby Medical Center, Kuala Lumpur, Malaysia. Over to you, Dr. Vival.
So thank you very much for this opportunity. Rajesh, can you share the slides which I sent?
Yes, sir. Kalpesh, please share the slides.
Yes.
So good evening, everybody, and welcome to this panel discussion on TNBC. So we're running late. We'll focus on early TNBC, and if time permits, then we can go on to the metastatic disease. So I thought we'll put things into perspective by way of discussing a case which is a fairly common presentation all over the world, I think. So can I have the first slide? Go to the case, please. Okay, so this is a young lady, fit person, 2.8 centimeter lump in her left breast, and she has a strong family history with mother and elder sister having a history of breast cancer. She has no comorbid illness, and we live in a different part of the world, but we can say that she can afford everything and she wants the best. So can I have the next slide? Okay, so my question to the panelists would be to say Dr. B. Ramos, as to what tests would you like to do? Can you show the next slide, please? Dr. Ramos, please.
Yeah, a young female. I would like to, at this point, request for GBRCA test.
Okay, and you look for the metastatic workup, right?
Yeah.
So which is done and which is negative. In the MRI and mammography, you do see a 1.3 centimeter single axillary node. So I think that is the summary of the case, that you have a tumor which is around 2.8 centimeter with single axillary node, metastatic workup being negative. Next slide, please. So, so the question to Dr. Khadija would be, so what would you do in this patient? Would you, in your country, go for chemo or opt for surgery?
I think we will go for chemo in our country because it will be, we will have an idea on PCR, and we know that PCR is a prognosis. So we will go for chemo, for anthracyclines and then docetaxel.
Yeah, we will come to that question. So in your country, what tumor size do you, go for chemo instead of surgery in TNBC?
Over 1 centimeter, we will go for neoadjuvant chemotherapy.
Okay, so that's very interesting. 1 centimeter and above, your medical oncologists are asked to take over, and the surgeons are willing to, request you to give chemotherapy. So Dr. Mastura, what is the practice in your country?
In my country, we have an increasing presence of multidisciplinary team discussions. So any patients with triple negative breast cancer that is more than 2 centimeter, we will discuss neoadjuvant treatment. But in a patient who is young like this with family history of cancer, then more than 1 cm, we will do neoadjuvant treatment, and therefore we have time to actually do the germline BRCA testing, because these are the patients whom we would consider to have possibly high risk for disease, especially in her with node positive disease in the beginning.
Right. So I think what I'm getting to hear from both the panelists is, so if it is node positive, then maybe the tumor size doesn't matter. But if it is node negative, well then 2 centimeter and beyond. I'd like to hear from Dr. Nadia as to what are the guidelines from ESMO and what is the practice in her country regarding the selection of chemotherapy versus surgery in TNBC in early breast cancer. Dr. Nadia, please.
I think you've summarized it very nicely in the larger node negative as well as in all node positive tumors. In this particular patient, we would put a clip in because she only had has one lymph node, so we could go for targeted axillary dissection later. So clip in the tumor and the lymph nodes, and she would get in our country mostly EC followed by paclitaxel and carboplatinum. This
we'll
would
come
not
to
be
that
a
now.
patient where I would apply for immunotherapy in an off-label setting. We don't have registration yet in Europe.
So I wanted to ask you this question because two of the panelists said they would go for neoadjuvant even if it is 1 centimeter. And I don't know what is the lymph node status. So if the lymph node is negative and the tumor is 1 centimeter, would you go for neoadjuvant or would the surgeons take over?
In our country, we see those patients in an interdisciplinary setting in the breast center. So there is no specialty who has first grab on the patient, so to speak. We discuss this together, and it makes sense in a 1 centimeter tumor. You have nothing to lose. You can tell the patient about the response and about her chances for cure, and you can escalate if there is still tumor left. And she has a very high chance for PCR if she's only 1 centimeter.
So I think that's a very, very important take home for at least our physicians and our surgeons in at least India, because the current practice is 2 centimeters and beyond to go for neoadjuvant chemotherapy and not to give chemo unless you're node positive or the tumor size is more than 2 centimeters. So it is very interesting to note that the threshold for administration of neoadjuvant chemotherapy in TNBC is going down. Dr. Nadia, you want to say something? Dr. Nadia, you wanted to say something?
No, I couldn't agree more. I mean, in the past, we used to do neoadjuvant just to sort of tell the patient what her prognosis is. But since we can actually modify therapy based on PCR status, I think there is no disadvantage in doing that. In the HER2 positive setting, we do have these data for the very small tumors that we can go with primary surgery and de-escalated therapy afterwards. In the triple negative setting, we don't have such data.
Yeah, no, but Dr. Nadia, the question is not no disadvantage, but the question, which the surgeon would raise is, do you have data to support the, better survival in a tumor which is 1 centimeter?
We have the indirect data that if we add capecitabine, we improve survival. Right. So in those few patients with a non-PCR, we could actually help them. And from a surgical point of view, once the tumor is properly clipped, it's very easy to do this surgery after the neoadjuvant therapy, and it may even be better cosmetically in patients with a small breast. So I mean, the surgeon will get to the patient in any case. So I don't see the rush of upfront surgery here.
Okay. So any of the panelists?
Can I add something, Dr. Shah?
Yeah,
I agree with Prof. Nadia Habek, but it's just that I feel that when we're treating young breast cancer patients with triple negative breast cancer, especially if they have risk for BRCA mutation, then it's no longer about operability to me. So if they have 1 centimeter tumor and we are able to see how they respond to your neoadjuvant treatment, and therefore after that you tailor what will be the subsequent treatment, that will be basically what I will look at, rather than just the tumor size or node positivity or negativity. I know that in clinical trials like the Olympiad trial, where they only enroll patients who are more than 2 centimeters with triple negative breast cancer. But in real life setting, we do look at individual patients, because we do not want to miss that period where you can actually identify patients who are at high risk for recurrence and give them a treatment as early as possible.
Absolutely. So just digressing a little, Dr. Khadija, is this true even for HER2 positive patients, the role of neoadjuvant? 1 centimeter? I'm just digressing from, yeah?
No, it's 2 centimeters.
Okay. Dr. Ramos?
Yes. Yeah, for me, the main indication actually for in my thoughts for neoadjuvant treatment would be the fact that she has TNBC. No? And for these patients, I would like to offer the neoadjuvant chemotherapy in the hope of achieving PCR and improving the survival. So
I think that is clear. So Dr. Nadia, I think before I move on, is this applicable to HER2-neu also, like 1 centimeter threshold?
No, in HER2 positive, we have the data from Sarah Tulani that tumors like up to 2 centimeters node negative have excellent outcome with primary surgery and 12 times Paclitaxel plus Herceptin for 1 year afterwards. So there is no need for neoadjuvant therapy. The actual study also showed that that was true until 3 centimeters, but there was only like 10% of the patients. So in Germany, we would say HER2 positive up to 2 centimeters, we would take them to primary surgery. In countries where you have the availability to give pertuzumab in the adjuvant setting, because about 10 to 20% of your so-called clinically node negative tumors will turn out to be node positive after sentinel procedures. So you should have the ability to escalate medical therapy in those tumors. If you don't have the availability of pertuzumab in the adjuvant setting, only have it in the neoadjuvant setting, I would even take the smaller tumors to a neoadjuvant approach.
Okay, so I think let's move on with the case. I think we are behind schedule, but we have covered a very important subject of the size. So this patient is GBRCA positive. And so what is the chemotherapy option, Dr. Khadija, in your country for such patients?
We use anthracycline, so AC docetaxel or AC paclitaxel.
Okay.
We don't use carboplatin.
What about checkpoint inhibitors? What about checkpoint inhibitors?
We don't have the authorization in our country.
Okay.
Not even in the metastatic setting.
Oh, okay. Dr. Ramos?
Yeah, the most commonly used would be taxane and platinum, as well as the anthracycline, 4 cycles and 4 cycles of docetaxel.
Okay, this patient is BRCA positive, BRCA1 positive. So Dr. Mastura, if you have the immune checkpoint inhibitor, 522, would you like to use that?
Actually, we have access to that. And I have already been using pembrolizumab together with the anthracycline as well as paclitaxel. Just that it's quite kind of hard to give our patients 8 cycles prior to the surgery. So sometimes we give just 3 cycles of EC and 3 cycles of the platinum taxane with or without platinum together with pembrolizumab. And the PCR rates have been quite good. It's just that after the surgery, if they have a past CR and then I do not give them any more adjuvant pembrolizumab after that. But if they have heavy tumor load, means that non-PCR is quite heavy, and then I will give them the adjuvant pembrolizumab as per chemotherapy.
Yeah, there are a lot of issues, what you are saying, which I want Dr. Nadia to address. So she's saying, Dr. Mastura is saying, I can give half of the chemotherapy first, and then take a call on the continuation of pembrolizumab in the adjuvant setting, depending upon PCR. So do you agree? And what is your practice currently for using ICI or immune checkpoint inhibitors along with chemo in the first line new adjuvant setting?
So we don't have approval yet. And at our site, we still have the trial open in the adjuvant setting, so we could put patients into this big trial. And we have decided that we would file for an off-label application in patients with a large local regional tumor burden for the time being. And with regard to splitting that, I don't agree. I think that is not evidence-based. We have no idea what the adjuvant checkpoint inhibitor therapy will do without the neoadjuvant component, because it's a completely different setting. You don't have a tumor in there anymore. So what we will do is, because we don't have the pembro available, we would start with the anthracyclines, and in that time ask for the off-label use of pembrolizumab in those high-risk patients. And for the node-negative patients, for the time being, we would just continue with our standard chemotherapy and wait for approval.
Right. So Dr. Nadia, when it becomes available, so are you going to use it, for the full neoadjuvant chemo, and then you will use in the adjuvant setting for that period, irrespective of the CR, whether you get PCR or not?
I think this is a question of where you practice and what your availabilities are and whether patients need to pay themselves. So in a country like Germany, once it's approved, we can use it and it's reimbursed. I would just follow the Keynote 522 data set, and we will have a second wave of studies trying to sort out the de-escalation with immunotherapy. For example, in our ADAPT trial, we had, like, after 12 weeks of nab-paclitaxel, we had 50% PCRs. Those patients do not need immunotherapy. So what I could foresee is that we do a sort of an induction chemo in those patients with a clinical response. We take them to surgery, and the patients without a clinical full response, we would continue in the neoadjuvant setting and add checkpoint inhibition. But this should be done in trials first before we do this in clinical practice.
Right. So I think the message is that the therapy is evolving. Before I come to you, Dr. Mastoura, I think we have Dr. Bonetjar from Algeria. So I'd like to have his opinion on the use of neoadjuvant chemo and immune checkpoint inhibitors in their country for TNBC. So Dr. Bonetjar, please.
Thank you very much. In Algeria for TNBC, you used the neoadjuvant for IC and for paclitaxel in 3 weeks or 12 weekly. In adjuvant, you check the PCR. Sometimes you use the capecitabine in adjuvant, and you never use the CD-CAT or immunotherapy in TNCB now in the moment.
Okay, thank you. So Dr. Mastoura wanted to say something.
I would thank you. I want to ask Prof. Habeck about the Japan Nuvo study with durvalumab in the neoadjuvant setting, where giving it post-surgery in those patients who did not have PCR did not translate into benefit. So that could be the basis of de-escalating treatment after a patient has had a path-CR following the Keynote 522 regimen. What do you think about that?
Well, I mean, Jepro Nuevo was not meant to be a registration trial, so it's, I think, underpowered to give us definite answers. It's very interesting hypothesis generating for the second wave of trials in the neoadjuvant setting involving immunotherapy. And I think one of the de-escalation focuses could be to not give the adjuvant therapy once you have a PCR, but I don't think you can sort of combine Keynote 522 and Jepra Nuevo and sort of get a mix of therapeutic strategies. Those are different checkpoint inhibitors, and you've seen how sensitive these checkpoint inhibitors are to their particular trial setting with the trials with Atezo, which was not where the data were not reproducible if you added other chemos, for example. So I would be a bit cautious, and I think we should start these trials around the world in order to get a better feel on how to use immunotherapy in early triple negative.
Right. So Dr. Nadia, I think it's quite clear that in the neoadjuvant setting, you don't need the PD-L1 testing. Is that acceptable with pembrolizumab? Is that the message very clear? Dr. Nadia, please.
Yes, I mean, I showed you that studies, both in Passion 031 as well as the Keynote 522, did not show that you need PD-L1 status to indicate the immune checkpoint inhibitor. We have no idea why this is different from the metastatic setting. One of the reasons could be, like we saw from Giampaolo Bianchini's data with the NeoTrip study, that you see an upregulation of PD-L1 with the first chemo cycle. So I think it could, and that's also something we saw like in the Jepra Nuevo, that in the window, if you have immunotherapy, things happen in the tumor. So we don't fully understand that, but for the time being, no biomarker.
Right. So let me just, ask this question, which is the final question. So this patient is BRCA1 positive. So after, a neoadjuvant chemo and surgery, the sentinel node is either you have a PCR or there is no PCR. So what is going to be the approach for the PARP inhibitor, olaparib, if the patient has PCR and if the patient has no PCR? Dr. Nadia, please.
As I said, we decided we don't have an approval yet for based on Olympia in Germany. Would be an approval extension because olaparib is available, obviously, in our country. But we decided to file an off-label application for all patients that fit the Olympia criteria because the hazard rate around 0.5 is so impactful that we would not forego this therapy. So we would opt for the PARP inhibitor instead of capecitabine in patients with non-PCR. And in patients with PCR, there would be no further therapy according to current guidelines, unless you treat the patient based on the Keynote 522 study, then obviously adjuvant pembrolizumab would be in order.
Will be continuing. So any thoughts? I think I need to have comments from all the panelists on this for the role of PARP inhibitors in the PCR versus non-PCR setting. Dr. Ramos?
Yeah, it's just good that we all have these options now for TNBC when we used to have limited with the chemotherapy. And yeah, so the olaparib is the newest one and really exciting addition to our arsenal for TNBC.
Yeah, Dr. Khadija, please.
I think it's a very good option, but unfortunately, we don't have this drug in our country.
Okay. So, Dr. Boneja, do you have this olaparib in Algeria?
Now in Algeria, just you use for the moment just chemotherapy, and I think is this option. It's a good option for the patient for TNBC because we have another option without chemotherapy.
Okay, so Dr. Mastura, you'll use PARP inhibitors in TNBC if there is no PCR.
If it's non-PCR, that is something that I can discuss with my patient if they are aware of the risk and the potential benefit that they might get because they do not have a PCR and of the Olympia results. And since we have olaparib, if the patient is willing to pay and know all this, then I'm willing to actually give it for a year for those patients. But if let's say the patient has had a pembrolizumab in the neoadjuvant setting and they have a huge burden of tumor load post surgery, then that's actually a dilemma for me. Do I continue the pembrolizumab in the adjuvant setting plus the olaparib, or choose between two? So yes. Yeah, so that is something.
So that is the debate. Yeah. If you don't have a PCR, because adjuvant pembro, as Dr. Nadia said, will continue for maybe a year or whatever. So you need to choose between the two. I don't think you can combine them at this point in time because there's no data for that. So I think we've covered fairly, relevant points as they are emerging in early TNBC, vis-a-vis the role of immune checkpoint inhibitors. We discussed the CREATE-X study, we discussed chemotherapy, and of course the PARP inhibitors. So I think we are running behind schedule, and actually I have to rush for another talk. So, Rajesh, are you there?
Yes, sir.
I think we can conclude unless there are some other questions, because all the esteemed panelists are available for any question answer here.
Thank you.
So with this, we come to, I thank all the panelists and thanks for the organizers to invite all of us here. Thank you.
Thank you very much, sir. And I have missed introducing Dr. Khadija Medab from Tunisia at that time, because Dr. Medab is Associate Professor, Medicine School of Tunis, University of Tunis, Al Manar, Department of Medical Oncology, Salah Ajaz Institute, Boulevard, Avril, Tunis. And in the panel, we had Dr. Ada Boneja from Algeria. He is Chairman of Medical Oncology, Department of Anti-Cancer Center, Algeria. He is Professor of Medical Oncology at Bida University, and he is President of Algerian Society of Training and Research in Oncology, SAFRO, and Vice President of Arab Medical Association Against Cancer, AMAC. And with that, I will take opportunity to thank Dr. Shyam Agarwal, Dr. Nadia Harbek, Dr. Ramos, and Dr. Mastura Yusuf from Malaysia. Thank you so much for a wonderful discussion. And we had 1,000+ delegates logged in last Saturday and this Saturday. Very, very useful discussion. And now I would, all good things comes to an end. I would request Dr. Govind Babu to give concluding remarks. Dr. Govind Babu sir is president of ISMPO. Sir, over to you.
Thank you, Rajesh, and let me congratulate you for this wonderful session that we had in the last 2 weekends. So let me start by thanking the Malaysian Oncology Society, the Philippine Society of Medical Oncology, the Thai Society of Clinical Oncology, Manage Health Foundation and UICC, and of course the Emirates Oncology Society, the Indian Society of Oncology, and my own Society of Indian Society for Medical and Pediatric Oncology. And also Mylan and Viatris, the 2 companies who have supported us with educational grants. And of course, I must thank Mice Ideas, including Rajesh, for having put together such wonderful program. And it's been a great experience for me as well to get all the societies together, interact with so many of the wonderful speakers, and 2 days of great learning for me at my personal level. So let me also thank all the speakers for both the days, including the panelists, the moderators, and the delegates, of course. I think we all have benefited very much from these 2 days, and I hope this sort of meeting should continue as an annual event. So thank you very much. Good night and stay safe. Thank you.
Thanks.
Thank you very much, sir. Attendees can download certificate from the portal by submitting the feedback form. And thank you very much. Good night.
Thanks everyone.
Good night. Good night.
Happy weekend.
Bye bye.
You too. Bye.
Bye.